For those of you who don't know what rural health clinics are, they're very similar to FQHCs. I know there's some FQHCs in the room today, but I'm the rural health clinic administrator. We're actually a hospital-owned and hospital-run rural health clinic. And I'm going to talk a little bit about, so I'm technically a hospital administrator. I know, don't throw anything at me. But we're going to talk about dental pain in the emergency room. I know that was mentioned earlier in the day. But we're going to talk about dental pain in the ER and try to help you frame that and hopefully give you a little bit of skills to help advocate for what you want to advocate for. I call it the unavoidable avoidable because I really believe that it's true. It's both unavoidable and completely avoidable at the same time, sadly. So here's a picture of my dentist, Dr. Benjali, and our public health and hygiene practitioner. We have 3 rural health clinics. In one of the clinics, we have 1 chair in one of our 3 rural health clinics. Grossly underserved area. And so Jessica Brennan is here and Dr. Benjali are here with our new sign that says dental on it, which is really nice. And here's Jessica. We had an open house at our rural health clinic, and one of our patients was walking through our rural health clinic, and we said, we have a dental service here. And the patient said, oh, dentistry, that's a rich man's luxury. That's a direct quote. And if you don't realize that's the perception that people have, that's not something that's accessible. Dr. Benjali and Jess are not smiling because it's a rich man's luxury. They're smiling because they fly in the face of that every day, and we provide dental services to people who would otherwise not be able to have it. So what I want to do for you today is help you identify or quantify what is an avoidable emergency department visit for dental pain. Also want to help you create a case for interventions and for policies. We had some policy folks here this morning. Those speakers were great. We're going to talk a little bit of anecdotal, use some data. Somebody mentioned that we don't have enough data. Hospitals have a ton of data. And also a financial case for these interventions and for policies. And I'm going to talk a little bit about some of the best practices that we've either learned about or stumbled upon or try to implement to take care of dental patients in an underserved area. So, but the story's going to start with John E. Morgan. It was kind of chilly out this morning. Has anybody here ever had long underwear with the 3-dimensional waffle stitch? Well, you may not know this, but the man who patented that waffle stitch was John Morgan. He was from Tamaqua. That's where our dental clinic is. That's the guy in this picture. And in the year 2003, he wrote a personal check for $1.5 million, slid it across the table to the hospital president and said, I want you to build an emergency department to take care of the people who helped me build my wealth. And we did. We built the John and Dorothy Morgan Emergency Services Department in Coaldale, Pennsylvania. So this is the Miners Hospital in Coaldale, Pennsylvania. So I'm sure you have a picture in your mind of what that looks like. So we built an emergency department, put his name on it. In 2018, a few years after John passed, his foundation gave us a $4 million grant to keep people out of that emergency department. Literally said, we want you to innovate, come up with strategies to keep people who don't belong in the emergency department out of the emergency department. That's a big picture of 2 different ways of taking care of healthcare, two different generations even, about what the priorities are. So that's where we've stumbled upon some of these things. That's why I'm standing here, because we were able to spend some time and money on this. So I want to start with, what does an avoidable emergency department visit mean? And it means something different to the philanthropists, the Morgan Foundation board. It means something different to the patient. I don't think a patient in dental pain thinks it's avoidable. They certainly believe it's an emergency. It is to them. We see them all the time in our emergency department. An avoidable visit means something different to our ER staff, whether it's a doctor or a nurse or advanced practitioner. It certainly means something different to our hospital administration. We see these as numbers on a chart sometimes, and not all hospital administrators. It certainly means something different for policymakers as well. And I know there's some payers in the room. What's an avoidable visit from a payer's perspective? And then also our community health department. We do a lot of work around oral health in our community health department, and they may have their own ideas of what avoidable emergency department visits are. So when somebody gives you $4 million, you have to get pretty specific. So we had to first figure out what the heck is an avoidable emergency department visit. So I don't know how many hospitals are in the room. I suspect not too many. But your hospital, your health system that's in your neighborhood has access to this information and this data, and I'm sure would want to collaborate with you if you're going to help avoidable visits, avoid the emergency department. So the emergency department visits, what we did was we had to define it somehow so we could track and measure it so we can go back and ask for another $4 million after we spent the first $4 million. So we looked at the data, we talked to our emergency department team, we put together an inter-department collaborative group, and we uncovered that every emergency department visit is given an ESI number from 1 to 5. And it's an emergency services index. It tells you how much, it's not really avoidable or unavoidable. It tells you how much services the staff thinks this patient is going to take for this visit. And so a 1 is a lot of services, helicopter, the most services that you could possibly imagine. And a level 5 is a low-level visit, not going to take a lot of visits at all. And so we use this as shorthand, and I would encourage you to work with your health system and the emergency department that takes care of your dental patients. And so we're using the ESI as shorthand. That's not technically what it is, but it's a good shorthand. So level 4 and 5 is low-level visits, not a lot of services, because frankly, when somebody comes into an emergency department, our emergency department staff is like, what are you doing here? This is a dental visit. You should go see your dentist. And so maybe give them an antibiotic or give them pain medicine and send them right back out the door. And so we are using level 4s and 5 ESIs as the definition of avoidable emergency department visits. So we have data. We could pull data. This is the data for all 14 of our hospitals, including our small rural hospital. And we could see what percentage of our visits in the emergency department are level 4s and 5s. You can see them here. And you can see it by year. If you look at the fiscal year 4, under fiscal year where it says the number 4, those 4s and 5s, you can see in 2021 we didn't have a lot of level 4 visits because of COVID. People were avoiding the emergency department. So we could actually track how many of these low-level visits, quote-unquote avoidable visits, we have. And not only can we see how many we have or what percentage they are, we could also get pretty specific about the data. We could list them by PCP, by primary care provider. There's a lot of pediatricians on this list often, but you can see that the biggest one is unspecified. People with either no PCP or they don't know who their PCP is. And then you could see in the middle chart, you could see the top 25 diagnoses in the emergency department for level 4 and 5 visits, for avoidable emergency department visits. The top one is viral upper respiratory infection. The second one is unspecified. And the third one is upper respiratory infection. So one is with cough and one is without cough. So I'm going to lump those two upper respiratory infections as one. So really, dental pain is one of the top in our network, and it certainly is at our rural hospital as well, but is one of the top diagnoses for avoidable emergency department visits, all right? And if you don't believe me, that's okay. The people who gave us $4 million believed it. And so we were able to start tracking these numbers and start looking at this. And also we could pull the numbers by payer type. So you could see that by far the level 4 and 5 visits are managed Medicaid. You can see that that's the predominant payer class for our avoidable emergency department visits. So what this does is this starts to get the wheels turning about who's paying for all of this. And so I call it the unavoidable avoidable because certainly, if we could have our patients and our communities and our water systems and everybody understanding the importance of oral health and oral health interventions, this would be avoidable. If we had really good prevention programs where we made sure that not just children but adults have preventative oral health care, this would be avoidable. If we had an oral health delivery system that had enough providers, had enough access points, this would be avoidable. If we had enough providers for those offices, and if we had real access, this would all be avoidable. And frankly, if we had a payer model that made it financially feasible to operate a dental clinic for patients with no insurance or medical assistance, this would be avoidable. And I would like to put this in your mind that our emergency departments are part of our safety net for oral health. It is perfectly clear to me after doing this work since 2018, specifically on avoidable emergency department visits, that the emergency department should be considered part of your safety net system. We all think of the community clinics, FQHCs, RHCs, free dental clinic day at the stadium or whatever we're doing as safety net stuff. We see where they're coming into the emergency department. So making your case for interventions and policies, use the data, find out what this is costing your health system, because then you have not only a health system that is financially incentivized to work with you to avoid those avoidable emergency department visits. You also have payers. I know there's some payers in the room. You have payers who are paying the bill for all these emergency department visits. So get that data, use that. Use the anecdotal, HIPAA compliant anecdotal. I'll tell you a very quick story. 40-year-old woman who was a patient in our area, passed away, leaving 3 children orphaned because she had an infection in her mouth due to delayed and no oral health care, no access to oral health care. So she has 3 children that are still alive, still in our community, and she lost her life because this is very serious health issues. That's an anecdotal story. So financial costs, the true costs you can see here, just for our rural hospital, you can see what our charges are for a managed Medicaid ER visit, and you can see what we actually get paid. So your finance director at your local hospital and your health system should be part of your conversation, because they are a big part of the payer and who's paying for it, whether it's subsidized care, whether it's part of the charity care that they calculate. Somebody's paying the bill for that care. Best practices. So what do you do in a rural community that doesn't have a lot of dentists that are seeing patients, period, let alone patients with no insurance or Medicare or medical assistance? So what do? You focus, and Jessica will tell you, we'll never get ahead of it by taking care of people with infections in their mouth. You have to go upstream as far as you can and do preventative care. Innovative things like integrating with your primary care office, because sometimes that's the only oral health exam that a patient is going to get. So your FQHC providers, your rural health clinic providers, your community clinic providers should understand that the mouth is part of the system, and whether they like it or not, they're doing an oral health assessment because a lot of times it's very clear. I'm going to talk a little bit about big health systems, because a lot of our hospitals, I've been in healthcare for 16 years, a lot of the small standalone community hospitals have collapsed into some large systems. So the system that St. Luke's has is probably similar to any large system that's near you. So I'm going to talk a little bit about referrals within the system and follow-ups within the system as a best practice. And then, of course, advocacy, what you're doing today and what you do when you go home, is a big part of it too. Preventative care, doing that, more care, doing as much as you can in the primary care office. Your kids are going to come to your primary care office because they need vaccines to get into school. They need sports physicals. They're going to come in. So we want to do as much oral health care and oral health prevention as we can in that setting. We also, even though we have very small staff, we have a 0.6 dentist, and we have 1 public health dental hygiene practitioner. That's our staff. That's the entire staff that we have. Yet we still find time to come to this event. We also find time to go into our Head Start programs, into our school to do the screenings, and we do preventative care. We also go into a local nursing home that's owned by the hospital. So our hospital loves us. Even though they lose money on our service, we're a dental service that they don't have access to otherwise if we're not there. So this is a picture of Jessica doing a cleaning with that cool kid with the sunglasses in our Head Start program. And we also do outreach, because if you remember, I said it is avoidable if we can get our patients and community to understand the importance of oral health. So here's Jessica and Dr. Benjali at our farmers market talking about oral health. And the other photo is at the parent night at one of our preschools. And so integration with primary care, having a discussion with your urgent care centers as well, because just like I could pull data for our emergency department, your urgent care centers in your neighborhood are also seeing dental pain, and so they also have an incentive to not do that anymore or do it as little as possible. So you want to make sure that they're doing that. We're lucky, I think, because our rural health dental clinic is part of our hospital system, but it's also not luck. We started the rural health clinic because we were seeing these issues. All right, so just a real quick best practice in terms of referrals and follow-ups. We all have electronic medical records. A lot of us have the same electronic medical record or similar, maybe different versions of the same one. But when you have these electronic medical records, it's really easy to not only get data, but input data. Referrals are easy. It's really easy to understand. It's a blessing and a curse to understand the scope of the issues that we're dealing with. So I'm going to show you just a little flow chart. In Epic, we do, the Epic is our electronic medical record. It's where our primary care providers, it's where our emergency department providers, it's where our urgent care providers, input their order for a referral. We refer to dentistry just like we refer to any other specialty service, okay? So there's a place in there. We train our providers to do this. It depends on which system they're in. If they're an emergency department or if they're an ambulatory site, they put in the ambulatory referral to dentistry, or they'll put in a referral to pediatric dentistry. They'll put in a referral to our sister FQHC clinics that are called Star Wellness Dental Clinics, or they'll put in a referral right to our rural health dental clinic. And so there is a process there. There's a little drop-down screen. In the after-visit summary that we hand the patient, it is either going to say referral to dentistry or it's going to say follow-up with dentistry. The best practice is a referral to dentistry, because a follow-up compared to a referral, follow-up means the patient, it's up to the patient to follow up. Referral means we're referring this patient to another provider. It's up to that other provider to follow up. So the medical community actually reaches out and engages that patient as part of the referral. So I want to make sure that you build, doesn't have to be this complicated of a workflow, but build a workflow that has not just follow-up saying, hey, thanks for coming to our urgent care center. Make sure you follow up with dentistry, because guess what? Dentistry is a rich man's luxury, and they're not going to follow up. Do a referral. Put it in somebody's in basket. Put it in somebody's work queue, so that somebody in the health system somewhere is following up with this. So again, just referrals from ambulatory to dental, and also from the ER to dental, and then referrals from our general dentistry to dental vans. So not only do we take referrals from our emergency department, our primary care office, our dental van, our outreach, we also send out referrals from our clinic. And so our FQHC clinics that are affiliated with us and our rural health clinic, we do over 4,000 outgoing referrals. These are people that need dentures, or they need a root canal, they need an extraction, and we can't take care of them, we send them out. So I would just like to put another thought in your head. If the FQHCs and the rural health clinics are referring out, if they're the safety net clinics, who are we referring to? Because frankly, there's nobody there at the other end, which is why that out basket is empty in this picture. So we have, and we could tell you how many of those referrals are completed and we get followed up on. But I could tell you that it's very, very difficult to find somebody to take our patients, and because they're all oversubscribed. So when our safety net clinics are referring out, there really isn't a safety net. So now you have 20 minutes to talk about all of those issues that I just brought up. But I appreciate your time and attention. Helen, I appreciate the work that your organization does to advocate, both in terms of policy and then also to support the communities that are providing dental care. So appreciate it. Thank you.